You can see it in her face and in her eyes. The appreciation and renewed sense of wonder now that her sight has been restored. Special moments that can be shared and cherished with her loved ones due to your skills and confidence. But how did we get here? As a surgeon, you know that the attention to detail at every step is what truly makes the difference. So when was that moment? Was it the moment the procedure was finished and sight was restored? Or was it before that, when the patient first looked into your caring eyes and knew that your skilled hands, along with amazing technology, would come together to make a successful outcome a reality? Each tool and device around you precisely designed and selected to provide you increased precision and confidence during every step of the procedure. But even before that moment came, there was the realization that something needed to be done. The moment you knew you were equipped to help restore vision and exceed your patient's expectations. It's easy to miss the beauty and the precious moments that are oftentimes right before us every day. Proving skilled surgeons equipped with superior technology and support can truly make wonderful things happen. The Cataract Refractive Suite by Alcon. Helping surgeons help patients enjoy all of life's special moments.
Promise you it is truly going to be a scientific feast today because we have a stellar faculty and we will understand the science behind such an important technology that has helped us and our patients to not only meet their expectations, but we are actually able now with the help of this our skill and technology to take them and improve their expectation beyond their expectation. So I think first thing is first, and there is some change in the order here, but the removal of the lens, clear or cataractus, is the fundamental step before we can add to his functional abilities to the patient. So there is no better person I know in our country than Hari Priya, who is a tremendous experience and a prolific surgeon, as you know her. So, Hari Priya, please.
Thank you, sir. So I think the Centurion Vision System is a few steps ahead of the earlier platform, both in terms of the fluidics and the energy delivery. So starting with the fluidics, what is different with this system, as we are aware, is probably the target IOP the surgeon can set. And how this is possible is because the bag goes into the BSS bag goes into the bay, which is behind the machine. And this bag gets compressed between two plates. And this would depend upon the inflow and outflow. And that will help the machine also maintain the IOP which the surgeon would set. And what this would translate to, obviously, is better anterior chamber stability. Besides the bag being compressed by this system, there are a few other things with the FMS, and that is the dual pump technology, which gives us better fluidics. And also they have the laser system, and this senses the inflow and outflow so that the target IOP can be maintained. Another important factor is also the tubing of the FMS. So the tubing in the Centurion FMS is smaller than the previous versions, and what this means is that there is reduced outflow from the eye and better chamber stability, so there's less chance of having surge as well. And this, I think, is a big advantage which we see with the Centurion system with the active fluidics. So the different aspect, like I mentioned here, is that one can set the target intraocular pressure. In this scenario, in amateur cataract, the IOP is set to be around 40. This is a 2.2 millimeter incision. It is using the Intrepid sleeve and the balance tip here. Like I said, what is important, like this IOP of 40 would probably translate to a bottle height of about 54. And I typically, when I used Infinity a couple of years back, my bottle height was 110 in all cases. So that I can now reduce, so I have a much more comfortable chamber stability, as well as the eye is more in the normal pressure range. So what you can see here is that the fluidics are not compromised at all. In fact, they are better even with this low IOP setting. And also I'm able to use the regular settings which I would like to use. A flow rate of about 30 with this cat at about a 550, 500 vacuum here. The second aspect is the energy delivery, and this is possible with the balance tip. So with the balance tip, what is different is that the torsional movement at the distal end of the tip is more than the mini flat tip which we're using with the Infinity. So it is 190 compared to the 130 which we had with the Infinity mini flat tip. While this movement is more on the distal end, on the proximal end near the incision, this is reduced. It is now 40 in comparison to 60, which means it is safer on the cornea and on the wound. So this is again a huge advantage which I see, and how that happens is when dealing with hard cataracts, I find this advantage is tremendous, that you have this much better cutting efficiency. So in a hard cataract like this, in this video I have used an torsional ultrasound of about 80, but I think now about 99% of my cases I would stick with 60, even with the very dense cataracts. So like I mentioned, with Infinity you would probably use 100 here. Here you can have the similar, or in fact much better cutting by reducing a torsional ultrasound. So the cutting is extremely good. Plus the vacuum also, you can choose to use higher vacuum because of the the better fluidics we have with this system. The IOP I have set here in this surgery is around 60, and the vacuum is around 650 and 38 flow rate. So please note that the holdability and the cutting is better here, and that is what makes it easy for us to be able to give more consistent outcomes even in these dense cataracts. So once the nucleus is fragmented into very small pieces, which is what I think one should do when dealing with hard cataracts, the emulsification is the next step, which is, I think the fluidics is extremely critical, that we don't have any chatter in the chamber, and the piece remains at the tip, so we don't have any endothelial, or reduce endothelial damage at least. And all these cataracts, I would use viscoelastic with chondroitin sulfate. So I would use Viscoat here, so we have the additional benefit of endothelial protection. And without compromising with almost the same surgical time, we find that the efficiency is enhanced. The energy, you can see here, is also pretty low. So where I had to use much higher energy in the earlier phaco systems, now it is almost half. And this is consistent with all the hard lenses. This situation is a hypermature cataract. So I think, I'm sure most of us would agree that hypermature lenses are one of the most challenging, not just with the rexes, which by itself is a challenge with the liquefied cortical material and the calcified capsule, but also for the phacoemulsification, because the bag is so weak, and with the calcified capsule there is a chance that this might want to come towards the phaco tip. Another important challenge here is that the nucleus is so wobbly. You have a very dense, firm cataract, a very hard cataract, and it's a wobbly lens, so we don't have any support below, and the bag is also weak. So this is one of the challenging cases, I would think. And even in this scenario now, I think we're able to do phacoemulsification consistently. Being meticulous, first trying to break the pieces into smaller quadrants. Like I said, we don't have the advantage of having additional support of the cortical or the epinuclear matter, so the lens pieces tend to fly around a lot more here. In this situation, the primary goal for any surgeon would be safety, so we do not want to compromise on the chamber stability. At the same time, we'd also like to have an efficient machine where you will be able to chop and emulsify a cataract as hard as this. So you have your safe settings, you have an IOP of 60, so your chamber is not too deep, it's just correct. With that same IOP, so the 80 IOP will be around 84 bottle height. And you can still have high vacuum and have your desired torsional level. So you're kind of combining both the safety aspects as well as the efficiency, so you give your patients the best possible outcome. So this next scenario is again something which most of us would see in our practices. A small pupil is a little bit of ectropy on UVA as well. And here, again, the concern would be that the iris would tend to come towards the phaco tip. And the surgeon obviously has to remain in the pupillary center and have that kind of chamber stability so he doesn't have to go behind, running behind the pieces. So we can see here, it's also a fairly hard cataract. So with the combination of having good cutting possibility and the right technique. I'm using a chop technique here where you don't have to go to the periphery. If you have to use a divide and conquer, I would suggest we use some iris retractors or rings to dilate the pupil. And again, like I said, chamber stability is extremely critical in eyes like this. So any kind of fluctuation will only cause the higher chance of the PC trampolining forward and having a posterior capsule rent, especially in a small pupil where it's just not a concern of less visibility, it's also a concern of less red reflex. So you don't have that much of visibility when you're working through a small pupil like this. So what we saw is a few situations where we tend to use, higher parameters, a hard cataract, situations where you actually have to use it. But I think the Centurion also has a great role in situations where you need to have absolutely safe parameters, like in a posterior polar cataract, or you have some posterior capsular defect, or a lens subluxation where you have a chance of vitreous prolapse during the surgery. So this is one such situation where we have a subluxation of about 4 to 5 clock hours. And in a hypermature cataract, while the nucleus was large, in this cataract it's a large nucleus and the capsule has densely wrapped around it. So the iris retractors are placed on the capsule, and the CTR is also placed in the capsular bag before the phacoemulsification. So we give the bag stability both from the front and from the equator as well. And following that, phacoemulsification is started. And like I said, we want to, it's a hard lens. At the same time, we do not want to increase the zonular damage or increase the chance of vitreous prolapse. So IOP of 40 is extremely comfortable. So you reduce the chance of chamber fluctuation, reduce the chance of vitreous prolapse forward. You also have the CTR in the bag, which opens up the bag well and prevents the chance of vitreous prolapse. So combination of these techniques and technology will help us in such situations. So using the tip, you kind of embed it down, so you're being very meticulous, break it down into very small pieces. In a cataract like this, you also have to have good cutting as well as holdability. So both of this will have to balance both of these factors as well. And without causing further zonular damage, I like to chop the nucleus first into small fragments and then emulsify these pieces. So I think the advantage of the fluidics here, I realize it more when I go back to the previous generation machines when I'm using a Centurion, that you have this chamber stability. The critical steps, obviously, we are always on the foot position. But as you're entering the eye, or especially when you're removing the probe, sometimes you tend to lift your foot a little too prematurely. And that phase, you find a little chamber shallowing and chance of a rent happening because of the surge there, which I think is also lesser with this active fluidic system. So this machine kind of compensates for some of those little maneuvers you might miss with your foot pedal control. And of course, it helps to reduce the surge and gives us a good chamber stability throughout the procedure as well. So this is table kind of gives us an idea as to what this IOP of 40 would look like, so about 54. So most cases today I use an IOP of about 55. So very hard lenses, maximum 60. That is what my settings would look like. But I think this is also possible that the different surgeons use this for a little while and understand what works best for them based on the kind of cataracts they deal with. Besides this, we also have other advantages with this system, that we have the AutoCert as a possibility, the wireless foot switch. The vitrectomy is extremely good. So with 23 gauge and it has 4,000 cuts, so it seems very seamless and you have good control on the vitrectomy. and it also can be synchronized with the Varion image-guided system. So I think in summary, the Centurion vision system does set a new standard in phaco technology, both in terms of the active fluidics, which provides excellent chamber stability, as well as the balanced energy, which optimizes the torsional ultrasound. Thank you.
Can I have the lights, please? Lights on, please. I think you don't need any justification. Look at this video, a wonderful combination of the skill and the technology. But I just want to reiterate some of the things which she showed it so very well, is that why we should be talking about this intraocular pressure. We never thought this terminology is new to me. I've been doing it for 35 years. And that's because the parameters and the intraocular pressure in the eye, which we surgeon as a rule, we never paid attention, is very critical and can be very crucial in some eyes. So I think the new dimension is to pay attention not only what happens on table, but also what happens next day. So on table, these active fluidics and the patented mechanisms of surge prevention really gives an exquisite control, and you saw a low bottle height or a low IOP and high IOP, high flow rate, high vacuum, everything doesn't matter. The chamber is stable because of that ability of this technology to maintain the pressure in the eye without any fluctuation. And a bottle height of 90 and 100 and 110, which I use every day for many years, translated to 80 millimeter mercury pressure. I never realized. If I had known it, I would not have started phaco at all and continue as I see it. Now, we are very kinder to the eye on table and get a control, but that's not enough. Why should we spend, because I'm happy with infinity, why is it that I should be considering this rather expensive technology? Although it is not expensive in terms of the benefits you get it, but on the face of it. And that's because on top of the performance and the control it gives, next day, what happens to the cornea next day, what happens to the blood barriers aqueous breakdown, what happens to the cystoid macular edema, and we had a session prior to this dealing with how to prevent cystoid macular edema. Nobody understands or give importance to the fluctuations in the IOP and the way you can control your parameters. So that is what is something we all should realize if you really want to be kind to the patient's eye, not only on table, but down the line. So, Sanjay, you've been using it for a long time, and I've seen your elegant videos. Tell us about it.
Yeah, in fact, what we did, that we wanted to explore the full capacity of this machine. And when we looked up the IOP status we can build up on this machine, we looked up, like Dr. Haripriya showed, up till 40 millimeters of mercury as an IOP. We went down to 30 IOP. And then we did a lot of our surgeries, and we did posterior polar cataracts, and we did subluxated cataracts like you showed, and we did cataracts in advanced glaucomas with CD 0.9. And we were very satisfied that here we have a tool, because of the active fluidics, where we can work at a 30 IOP, which is actually a bottle height of just 45. And then we went a step further, and we said the machine has a capacity of a 20 IOP. So the 20 sounded a little too much, that can we really do a phaco at an IOP of 20? So we set 20 as the parameter, and then we again did a series of cataracts in these difficult situations, and we realized that the machine works so well even in such a low IOP. 20 IOP is a bottle height of 25. Something unthinkable of more than a year back, like Dr. Vasada was pointing out. But then this is a new realm, this is a new area where we really need to work up and educate that yes, you can do something about these situations. So,
Thank you, Dr. Haripriya, for wonderful. I understand you have to leave, but thank you so much. I have been doing this lunch symposium for the last few years. I've never seen so many of my friends here like I see today. So thank you for coming, and thank you, Alcon, for putting up such a wonderful, informative and educative science that we needed today. We need to enhance our performance and for our patients. So thank you. But the reality is this.
Here's your tea, Mother. Oolong?
Yes.
Loose, not bagged?
Yes.
Steeped 3 minutes?
Yes.
2% milk?
Yes.
Warmed separately?
Yes.
1 teaspoon sugar?
Yes.
Raw sugar?
Yes. It's cold. I'll start again.
Well, I think this is the reality, and the demand is increasing, and I'm glad that it's demanding. So that keeps us, the clinicians and industry, on the toes, and we keep evolving after evolving, and we maximize the outcome of our cataract surgery. But mind you, you know that this focus now has changed not from the technical performance of avoiding PCRs and so on to the intraocular lens performance outcome. And in that regard, it was a good idea to treat cataract surgery as a refractive cataract surgery that helped us to refine our prediction and performance. But that's not enough. That's not the end point. Now we are shifting even further up. That's what I want to bring to your notice. So don't get satisfied with the refractive cataract surgery. Now we want to improve on the quality functional vision of the patient, and that's what we are doing. On that, the refractive cataract surgery will be an important tool, but our aim is now to give a functional quality vision. And patients really want extended field of quality vision for everything. They want stars and moon. So whether they are from that background or this activity or that, everybody wants that. Answer obviously remains in the multifocality. Now, having said that, there have been many multifocals like Technis, like Acrylisa, and obviously the glorious example is the Restore Plus 3, which gave that and catered the demand of the patients quite correctly and adequately for a long time. But then industry realized, we realized, and patients told us and taught us that intermediate vision was not as good as they were expecting. What is that intermediate vision? You know, of course, the laptops, the mobile, looking at the television and seeing mobile and so on in the kitchen world was not as good. They're okay, but not good. And therefore, they were good full range of IOLs, and who were absolutely fastidious of not wanting to wear glasses, that worked very well, and they could handle the dysphotopsia to a great extent, and they had to compromise the quality to some extent in trying to get the flexibility. Now, before I move on, I just want to recognize Samray Srivastava, my colleague, who is really helping me to understand this newer concepts in the IOL. But depth of field is something is very fundamental that we want. I want to see everything while remain focused at my target of interest, in front, in behind, and all around in the three-dimensional way. That's depth of field. Now, we all now want to extend the depth of field of vision for patients. And I want to share with you some basic knowledge which I learned once again from Shamresh, how you can achieve that. The simplest and the most effective way is to have low edge powers from 4, 3, and 1.75, 2.5, and so on. You can also extend the depth of field by small aperture, like aquafocus lens, like a camera implant in the cornea, or extended depth of focus, combining the Strum's conoid principles of diffuse focus and negating the Strum's conoid to some extent. You can't negate everything, though, to some extent by chromatic interplay. So these are the ways you can add the extended depth of field of vision. You have a choice of these three mechanisms. Now, what the low edge power does is very smart. Now, remember that same animation, the peripheral part is for a distance, one focus. So, crisp distance image. The lens works in all these ranges, central as well as distance. Remember, the central going to the focus, that's the distance. Even the periphery going to the distance. So maintaining the distance, crisp vision quality. But with the low edge, which has come up here now, with the limited, very, very thoughtful, well-planned number of rings, the height and so on, which enables and gives that missing depth of field of vision, which traditional multifocal didn't give that much. And that's what that low-powered IOL does. And that has changed the way we, the clinicians and the patients now look for that. So the best example is 2.5, but I want to tell you that there is another lens, another company, which also gives this low-powered. So this is not a new concept, but a concept which we find so good that you may not believe it if you're not used it. So what is that? The Restore 2.5 gives intermediate zone, that gives the crisp quality of distance and intermediate, because it's configured that way, as you could see in some racist animation, but also would need, therefore, low power. That's okay. Now, how can it be okay? Because I don't want reading glasses. Remember, 80% of the population across the globe, not only here in the US as well, and 80% of the population use 80% of their activity 24 hours time in distance or intermediate, whether you're a professional, office, driver, or a kitchen person, a professional banker, laptop. It's an intermediate distance. So they are very happy now because they never got such a vision with earlier lenses, the community. So this has been a hot cake for me, in my opinion. And this photopsia is actually practically not existing. I mean, you may have a little dysphotopsia or bother for 1-2 months, but because of this very calculated rings and the zone, it is, in practical terms, you don't need to worry about it when you recommend. So having understood that you therefore will need a reader glasses, and most of the guys don't need it. They don't mind it. So here is a situation that it is not 100% glasses free. But why we still do this? Because we have moved from refractive cataract surgery with no glasses to a better level of understanding and service to the patient, that we want to give a better quality vision. And reading aids at times is okay, because we in the process gain so much in the quality of, and that will change the lifestyle and will enhance the patient's life, I would say. But before you do that, the technical part, you need to have a profile of the eye and the rounding structure, but also the patient, his health, the psychology and everything. That's understood. So having understood the basics, I just want to tell you the 82-year-old lady who was very active, forgetful of glasses, and I keep forgetting even earlier than this age. So we suggested her +3 bilateral, and she's so happy she can do anything. But this is a school teacher of my children. She taught my 2 daughters in Loyola Hospital, and she now comes with a cataract, and she said, I'm okay, I want to travel. I am playing all these games because she's now retired, and she's very intelligent. So we did +3 restore, and here is with her father, very satisfied with her husband, as well. So you need to select the understanding the patient, what you want. Now here is an example of a 50-year-old bilateral cataracts IT professional, and would like to a good region, a good depth of field of vision, but also he was worried about multifocal. And he said, I've heard so much bad about it. Well, we counsel him for extended range of vision, that he will get good distance quality vision, and good intermediate, minimal glares and halos. But mind you, you may need a little reading for a fine print of thing. And he said, okay. So we used 2.5, restore both eyes. And he was so happy because he in IT, computer, they spent 18 hours, all waking hours in front of these boxes. And he was so happy that he didn't have to put the reading glasses on there. No. He only occasionally had to use, and it worked like a good quality monofocal distance vision and intermediate vision. So what it taught me then, in this case, that I can suggest all my potential monofocal patients this 2.5 restore without worrying about the dysphotopsia or unhappiness, provided that the ocular profile fits into that. So you can suggest it to 82-year-old lady, you can suggest it to young active individuals, and we have so many in our list. Sanjay also says that 30s, 40s, 50s cataract get earlier age. So we can suggest that also to these, because the distance and intermediate is what we are doing and helping them. So this one more example, unilateral cataract, mind you, unilateral PSC cataract, but he was also doing, in addition to the computer all day, he had a hobby of motorbiking on the weekend. So we have to take care of the negative part of this multifocality and also the crispness for his function, which was intermediate most of the time, and distance for his hobby. So we complemented distance and intermediate his requirement by putting 2.5, and we said you will need a 1.5 or so reading, and he was so happy. He was so happy, believe me, that these are the cases which convinced me that I wish I can put all my cataract surgery patients, provided that eye profile fits, all the monofocal lenses into 2.5. Unfortunately, that's not reality because the cost is an issue, and I'm not sure Alcon is the best example for that. But if it is there, it's a wishful thinking for me. I think all patients should have either toric lens monofocal or a 2.5, really speaking. That's the beauty of this thing. Now, this is somewhere else. My colleague in one of the central states of India, he had an excellent surgery, very good outcome, but he had a residual minus part, and he wanted an unaided vision. Unaided distance vision, so he was not very happy, so he came for the second eye. Now I have a problem, one eye, monofocal minus 1.25, excellent surgery. I had the challenge of repeating that quality surgery, so that's a challenge, but also make him happy that he doesn't wear glasses. So we decided him to give a 2.5 restore, a radiologist, and we complemented each eye, and we did that, and he was so happy that he's post-operatively unaided with both eyes together, was 6s as expected. His intermediate was so good, and he required about 1.5, 1.25 reading. So Restore 2.5 can be paired with a monofocal IOL or like a fakey clear lens as you saw in the previous case. So other eye refraction does play a role, and when you decide, always check bilaterally before you give a plan for this. But this is what has changed my incidence of multifocal implantation. I have many patients who wanted multifocal. I couldn't put it earlier because they had astigmatism, and 40% of my patients have significant astigmatism left at the end. So now that you have a restoratoric, you can deal that aspect so well, and you can make many more patients happy with this wonderful devices. So this is a retired police officer, bilateral cataract, and he is playing golf because he's retired, and they always did that in their job. They never did anything else. So he had this astigmatism, and he actually waited for a few months because I didn't have the restoratoric available in India at that time. So we did that restoratoric, and he was so happy, and he keeps winning his championship in his club, and every time he wins, he rings me and gets me some gifts. So this is what it is. But this is something many people like it. And it is a necessity in some cases, like that extended depth of focus. What's the names? Abbott lens. The Symphony. No, but it's Symphony? Symphony. That is a necessity for them to blend, because if they don't blend it, unlike 2.5, you don't need to blend. If you want a symmetrical, good performance, you don't worry about the blending. You have to depend on a monovision. With this lens, doesn't have to depend. But if you want to, for any reason, then some surgeons do that, you can, sure. And you can do with this also, like as we find in few patients. Although I must say, I'm a man, I believe that bilateral symmetry is the one I want. If I have to have, I want identical when I'm driving, walking, I want exactly same. I don't want a little less focus. It doesn't appeal to me, but I understand those who don't want glasses. You can use monofocal, monovision like this other lens, and in any lens you like. Even without any multifocal, you can do that. So you can achieve best. We have done few patients, not many, but this is one of the patients where this was a homemaker, bilateral cataracts, and as most of our ladies do, watch television, serials. So many are now coming that they remain so busy watching serials, knitting at times, and on WhatsApp. That's another thing, they remain busy all the time. In India, there is no other country which uses WhatsApp and SMS more than India, by the way, as you know. And you contributed to that. I have done it. So she wanted to do it without any activities, and then we suggested, why don't we do this? So we did a Restore Plus 3 to make her happy with her first thing, and then we did 2.5 down the line, and she was so happy that her objective of not wearing glasses was done, and she could do whatever she thought was going. She thought her vision was very good. So that's good. So what we are now doing is, in summary, what I've said is that now we need to consider every patient who is sitting across the slit lamp, and imagine it's you or your family member, and give the best. In other words, give the best in what? Give the best when you use the best technology, try to acquire it, use disposable items, use right adjuncts, and give the right IOL, which goes in easily, remains stable forever, whether it's toric, no rotation, or whatever, and then decide and suggest to them, and then give an appropriate strategy, monofocal, toric, multifocal, toric, matching, monovision, whatever, but do that. And that has changed my practice, and my satisfaction rate from the patient has never been so high as earlier. Always I had a lot of criticism. You did a good surgery, but I'm not very happy with the vision. That's very, very rare now. And finally, I just want to remind you, those enthusiasts, to keep coming to us every year in September, and those who are not, we have in 2nd, 3rd September a colloquium 2017, where traditionally we have one international guest. Last time it was Warren Hill, a year before was Osher. This time it is Dr. Graham Barrett. So those who want to come, you all are welcome. And thank you for your... And Sanjay, I would value your comments on these very briefly before you start your presentation.
We realized that a few years back, when we talked of multifocals, we were actually talking for distance and near. Now, presently, the concept of extended depth of focus is really catching on. And it is easier for us to explain to the patients the intermediary vision, because in my clinic, I tell them, well, now there are bifocals, there are trifocals, distance, intermediary, near. If I try to give you too many focuses, things may not work. I can best give you two focuses, distance and near or distance and intermediate. But if you take distance and intermediate, you get a depth of focus which looks after most of your requirements for routine activities, especially the ladies looking at distance, going to kitty parties, doing their housework. Intermediary will work much better. So once you start explaining the concept to the people, they start accepting intermediary, and then they start accepting also that, well, for very fine work, extraordinarily fine work, you may need a reading glass once in a while. So the surgeon is also safe that the person has to use glasses once in a while for reading, and the patient is also happy that the functional vision is much better than what we used to get with a monofocal. So, going on to the next presentation, there is not a company which does not have a preloaded IOL delivery system. Definitely there are advantages in a preloaded IOL delivery system, which is considered a better way of inserting an IOL than a system where the IOL comes in a separate package. You have to pick it up, you have to load it and then insert it. So, why do we need a preloaded delivery system? 4 major reasons. 1, it is consistent, predictable, and a controlled insertion with minimal incision. 2, your instruments, once used, you can throw them away, those instruments, so there is no need for post-operative cleaning and sterilization, and all that debris you're not bothered about. 3, since the IOL is preloaded, it saves on your OT time. And 4, it eliminates handling and misloading of an IOL, especially when people used to use their surgical assistant's help to load the IOL. And many a times we used to see that the loading was not done well, and while injecting, one of the haptics used to give way. So all those problems have been taken care of with the preloaded system. and the most important data which has come across of preloaded versus the non-preloaded. In a study of 25,000 eyes, 12 had postoperative endophthalmitis, and in this only one was in this category of preloaded, which is 0.08%, and 11 was in the category of the folded normal IOLs. That means they came in a separate packaging and they had to be picked up and then loaded and then injected. They were exposed to body fluids, they were exposed to eye fluids and various contaminants. So this is the biggest relieving factor for an ophthalmologist who does not want to face a situation of a post-operative endophthalmitis. And if we talk about statistics about reduced OT time, it was seen that about 6.2 to 12% reduction in OT time was seen with pre-loaded IOLs. This is the new offering. It's not new anymore, but still it's a new offering from Alcon to deliver a Acrysoft IQ IOL. And here you have a new injector system which has a tip which has a depth guard nozzle, which means that if you are placing it into the incision beyond a certain depth, the injector would not go. So you don't take it too deep into the eye and disturb the anatomy of the incision. Then there is a lens stop which is there so that the lens does not change its position during delivery, and when you're putting in the visco, it should again not change its position because that position is critical for a good IOL position while delivering the lens. Then there is this plunger lock which holds the plunger back till the IOL is ready for insertion, and this new feature, a tension glide plunger. That means it is a spring controlled system, and as you keep injecting, the pressure because of the spring will keep changing, so that once you are injecting the IOL in the eye, at the last stage when the IOL is about to come out into the eye, the spring will reduce the pressure so that the IOL suddenly just doesn't spring out into the anterior chamber and cause a PC rent or any other trauma to the inner tissues. So this video is going to show you the insertion of the UltraCert. This is the name by which this IOL comes, and the UltraCert uses an incision of 2.2. It is recommended that you use it under a good viscoelastic like the Viscoat. This is the tip with the depth guard. And the plunger, the way I have already described. So I'm just demonstrating you the depth guard in a little more detail. It just rests in the incision with probably the tip just showing beyond the incision. So you fill up this preloaded delivery system with visco up to this point, and then remove the stoppers, the two stoppers, and proceed the plunger forward. As you proceed the plunger forward, the IOL you can see is moving in this cannula. It is automatically folding onto itself in the position we want it to fold, and in this position you have brought this plunger till the end, and that is the position when you are ready to implant the IOL. So this is where the IOL should be when your plunger is at the end. Now a wound assisted delivery, which is almost injecting it, it's your choice, up to the edge of the guard or a little short of it. and then comfortably, as you move it in, the IUL opens out very, very slowly and expands to the position that you want it to. So the delivery is very controlled and precise. Okay, and here I am giving you an example of another lens, a popular preloaded system, a very good delivery system. The lens opens up very comfortably, but once in a while there is a little catch, and I could record that, and I'm showing that to you. The lens came in out pretty comfortably, but in the end, the trailing haptic seemed to come out with a little extra pressure. It was getting stuck, and I had to relieve it with the help of my side instrument. So we would prefer not to face such situations. And here's the statistics which shows that other lenses do have a problem in the preloaded delivery system with the 10% chance of the trailing haptic getting stuck. But with the Ultra Cert, there is no chance. And then we are looking at an option of how much does the wound stretch with an Ultra Cert versus some other good delivery systems. And we checked on Hoya, incision of 2.2, there was a shortage of time and just moving a little forward.
Yeah, I think, Saurabh, you decide the timing, but we'll have to vacate this room at the right time.
So
okay?
once the lens went into the eye, and we check the incision from 2.2, this is 2.4 I'm checking now. The 2.4 is going in, that means the incision is 2.4 or more. With 2.5 has also gone in, the incision is 2.5 or more. And with 2.6, it showed that it is not 2.6. So the incision was 2.5. So our last short video, I will just show the performance of the Ultra Cert, and the incision to start with was 2.2. And not 2.3. We did a phaco, and after the phaco, we checked the incision. That did phaco make any difference to the incision size? So we are checking with 2.3. 2.3 has gone in. That means during my phaco, the incision increased by 0.1, and 2.4 does not go in. So the incision right now is 2.3. And then I use the Ultra Cert to check, after implanting the IUL in the eye, what is the status of my incision. So a smooth delivery. And we are checking out with the incision with the gauge of 2.4, and it's not going in. So the incision is still 2.3. So this is a data of wound comparisons where the Ultra Cert is anything between 2.2 and 2.3, whereas other preloaded systems are showing a greater wound stretch. Thank you.
Thank you. I think that Dr. Bala, the next presentation, is a clinical associate professor in Sydney, Australia. He's also a section editor in the cataract section of Clinical and Experimental Ophthalmology Journal. And he's trained glaucoma, cornea, and refractive surgery. And he has contributed in understanding of the capsular thing in the lens-6 and other femtosecond cataract surgery and use. So, Bala, all is yours. Unfortunately, the time is an issue, and as brief as you can, Bala, please.
All right. Thank you very much, Dr. Vasavada, and thank you to Alcon for allowing me to share the podium with such illustrious members of AIOC. I'm going to keep, because time is an issue, I'm going to skim through some of the important points here. As you know, the technology is coming in leaps and bounds in our personal lives as well as in our professions. The technology that is coming in is, going to the next slide, the technology that is in the form of the Centurion, the LensX system, Aura, and Verion. And as you were saying, Dr. Vasavada, before, we'll go to the next slide, that once upon a time, 6/9 was considered, at least in Australia, was considered good vision. But now it's not considered a mark of success. And it's not just cataract and refractive, it's also quality of life. And we are grateful for this new technology that improves our results, but at the same time, it requires a significant amount of change in the OR from a surgeon's point of view. And so recently the Verion was introduced and the Alcon toric calculator changed to include the Barrett's formula. And now Aura is also coming around the corner, and we've just recently received our Aura and started using it with some promising results. Going to the next slide. You'll notice that in Australia, about half the day surgery at private hospitals use a toric alignment, a digital toric alignment like Verion, which shows you the importance that is placed on these sorts of devices. There is no extra remuneration for this purpose. It is just purely to get a more accurate result. Our toric uptake is considerably higher than most other countries. Overall, it's about 26%, and in the private sector, it's almost close to 50%. Going to the next slide. You will see that the Verion image-guided system is a new system where it can do a number of things, but mainly two functions are involved. One is as an alignment tool to align your incisions, capsular excess, and to align the IOL accurately. And at the same time, a lesser used function is as a keratometer. I'm going to the next slide. Here are two videos. I'm going to just play the left video for the second. Can we play the left video? So you'll see, going to the beginning of the video, if you could drag the cursor all the way to the left. Yep, click there. This is the system where the patient is sat in front of the Verion preoperatively. The Verion moves in and out. It doesn't just take one image. It uses an infrared system to take an image of the eye and take toric power. You take that image and go to the operating theater, and you take another image while the patient is lying down. So any cyclotorsion that is induced by the patient lying down is now matched with the preoperative image. Go to the next yellow tab. And we can move on to the next one. And intraoperatively, you can take another image. Both of these are aligned, and NEX is performed in this particular case, and you can then take the data into the operating theater to perform the surgery. At no point are you re-entering data again and again, so there is no error rate involved. Everything is preset. There is no risk of you putting the wrong lens. You can see in this particular eye, there's a lot of subconj hemorrhage, but the Verion has been able to align itself despite that correctly. And this is an early case where the blue dots are marking the correct positions, and it has aligned beautifully, and the wounds have been aligned. We go on to the next tab. Once the cataract is removed, the Verion can at all times give you a real-time image of the IOL alignment. The value of this is that if you were to do an IA, and you use bimanual IA, you get your alignment correct, and you can just constantly keep jiggling the alignment. If you go to the second video, please. In the second video, if you could play that and go to the last tab on that video. This is a patient who's had PXF, has got a small pupil going back. And while you're doing the IA, the pupil is small, so it would be difficult to find those markings of the toric IOL. And as you're doing the surgery, you can lift up the iris while you're cleaning out your viscoelastic bimanually, and you can ensure a much faster operation in this case. Going to the next slide. These are alignment aspects of the Verion, and it has been very easy to take up. The lesser used function is its keratometry, and in fact the keratometer performs very well when you compare to an IOL master. This is the data from 316 of our patients. If you go to the next slide, we looked at the data more carefully because sometimes you'd go into the operating theater and the Verion would say, don't put a T4, put a T2. At that point in time, if you're just using it as an alignment marker, that's okay. But the moment you get a doubt as to which IOL to be put in, then that needs to be examined further. And so here we have data from both the Verion and the IOL master using the Barrett's calculator. And I know this is a complicated graph, but if you could just concentrate on the left graph, that in the first curve is all the patients who are going to have a T2, and the Verion in some cases said put a T3, in other cases said don't put a toric lens. One T difference is not going to clinically impact any of the patients. However, if there is a 2T difference, well, that's going to have a significant impact on the postoperative outcome. So about 8% of patients, there was a T2 difference. And if you go and look at their postoperative refractions, if you just based your results on the IOL master, we had a difference vector, the amount that would, further correction that would be required to get to emmetropia of 1.2 diopters compared to the very
Dr. Bala,
0.56.
can you hear me?
Mind, these are both cases assessed.
Can you hear me, Dr. Bala?
And that's shown in the graphical form.
Saurabh, could you help us to communicate to Dr. Bala, please? Dr. Bala, I really, can you hear me? Can you confirm that he's hearing me?
Yes, I can.
Dr. Bala, I really, my personal apologies, and on behalf of the organizers, I really hate, but the point is that there is some mismanagement of the time on this end, and we really have to sort of thank you so much for all these wonderful things, and I really personal apologies. Thank you so very much, Bala. We really appreciate your time at this part of the evening there, and thank you so very much. And thank you all here for your attendance. Thank you.